fourth most populous country in the world, is home to 16 million elderly people, representing the largest number of older people in Southeast Asia, fourth largest in Asia, and eighth largest in the world. This number is growing rapidly, doubling over the past 5 decades, and is projected to make up a quarter of Indonesian population by 2050. As shown by population pyramids, changes in the population composition will result in several challenges for the Indonesian public health system. First, there's an increasing burden of degenerative and chronic diseases, along with the increasing number of elderly. As stated in Research 2018, chronic diseases are the most common disease in the elderly population in Indonesia. The increase of aging population and consequently the rising prevalence of chronic diseases will further increase the burden on the already struggling chronic care in Indonesia. Secondly, this increase in the aging population is complicated by increasing migration of young productive people to the city. This means that these older people may often be left unassisted, increasing the risk of associated health problems such as medication adherence, falling, and any other physical injury, as well as feelings of loneliness and mental health issues. Thirdly, since the aged care facilities availability is still low, many elderly in the country do not have access to necessary care to maintain healthy aging. This issue is worsened by inequitable distribution of healthcare facilities in Indonesia, with areas such as East Nusa Tenggara, West Nusa Tenggara, and Papua suffering the most.
To address the challenges, we are proposing a comprehensive program to improve the health of the elderly in Indonesia, specifically in Kupang, the capital of East Nusa Tenggara province. We choose the province as it has the highest elderly dependency ratio in Indonesia. Moreover, the distribution of healthcare workers in East Nusa Tenggara is found to be one of the lowest in Indonesia, with physician density in the region of only 0.03 per thousand population and nurse density of less than 0.5 per thousand population. This program will be initially rolled out in Kupang with hopes that its positive impact can be used as a basis for government to take over the program or even expand it to the higher level.
Our program is named Hakenmes, which is derived from Dawan, one of traditional East Nusa Tenggara languages meaning standing on your own feet. It will consist of 2 separate programs that target different population of elderly in the city: elderly with limited physical mobility and those who are still physically active. First, for those who are physically limited, we are proposing an informal carers program. This program is called Naumat Seun Umi, which means home visit. Secondly, to those who are still physically active, we are proposing Tawabakit Aumina, or Talks About Our Health, which is an elderly-led focus group discussion that will focus on structured education of chronic disease management.
According to Australian Institute of Health and Welfare, informal carers refer to any person such as a family member, friend, or neighbor who is giving regular, ongoing assistance to another person without payment for the care given. The objective of this program is to assist the elderly population with any physical disability to manage their condition at home and, when necessary, inform the local health office and local social service office where the elderly population needs further assistance. With this program, we are hoping to alleviate the burden caused by the scarcity of healthcare workers and reduce the costs associated with the provision of home care to the elderly. We believe that the use of informal carers will be more suitable for Indonesia compared to the option of using aged care facilities, which is not suitable for the Indonesian cultural values, or the use of telehealth, which might neither be feasible nor user-friendly. Naumat Seun Umi will be run with the help of youth volunteers from churches, local youth groups, and scouts, which are 3 prominent youth organizations in Kupang. Each of these volunteers will assist 1 elderly, and 12 to 15 volunteers will be supervised by 1 coach, which are healthcare workers from the local public health centers or Hakenmes. Carers will meet regularly per month with their coaches to discuss their visit reports and obtain health education training. They and their coaches will also be connected via WhatsApp chat group. Carers will be provided with a visitation checklist and will conduct a general interview to the elderly. This interview will cover topics such as the elderly's well-being, concerns about their health, and how they go about taking their medication. They will also be asked if there is anything that the volunteers can help with. At the end of the short interview, the volunteers will deliver a short health education intervention on topics relevant to the elderly's condition. As compensation, these volunteers will receive vouchers that they can use in local stores, book and music stores.
Our second program, Tawabakit Aumina, is a self-managed focus group discussion. We chose FGD as our second intervention for several reasons. First, FGD may serve as a platform for the elderly to maintain a regular social interaction and provide continuous social support for each other. Secondly, studies show that social support system is associated with lessened morbidity and mortality, loneliness, risk of mental health issues, and the risk of death among the elderly. In addition, by involving them in the whole program, we aim to empower the elderly and give them ownership of the program, with hopes of increasing their interest and adherence to the program. This program will be delivered weekly within community settings, such as churches, community centers, and community health centers, in conjunction with existing social gatherings where possible. The FGD will be conducted in a group of 15 people and led by peer leaders, which will be selected based on their commitment to training others and conducting regular meetings. Those coming from a health-related background will be preferred to be peer leaders. These peer leaders will receive initial training from healthcare professionals, such as pharmacists, doctors, and nurses.
The topic that will be discussed in the FGD is related to daily management of chronic diseases and healthy lifestyle relevant to elderly health condition. This will involve topics such as symptom management, medication use and adherence, nutrition, physical exercise, smoking and managing alcohol addiction, personal hygiene, and stress management. When necessary, the topics will also be adjusted to reflect current events such as World Diabetes Day and World Hypertension Day. There will also be bigger FGDs held monthly. In these FGDs, local smaller groups are gathered, with guest speakers such as doctors and pharmacists attending to deliver additional health education. Fun physical activities such as traditional mass dances will also be held at the end of the session.
Hakenmes is expected to start in January 2021, beginning with 1 year of piloting where we will test out the program in several districts in Kupang. In the first 3 months of the pilot, we will establish partnership with key stakeholders, including the local Department of Social Services, church, local youth groups of Karang Taruna, Scout Association, as well as local sports, books, and music stores. During this period, we will also promote Hakenmes through local radio, TV stations, local newspapers, and also social media to appeal potential youth volunteer candidates. We will then recruit and train FGDP leaders and informal care volunteers. The next 6 months will be plotted for the pilot program, followed by a 3-month period of evaluation and program modification if necessary. The full implementation of the program will take place in January 2022, where the program will be rolled out to all districts in Kupang. During the first 3 months of 2022, we will expand our partnership and publication, followed by 2 years of program implementation and ending after 3 months of evaluation. Accordingly, the total duration of Hakenmes will be 3 years.
By the end of this program, we will conduct a final evaluation in which we will evaluate perceived benefits from the targeted population using surveys, knowledge and capacity in self-management using a pre- and post-test, participation rate during the program measured by attendance. We will also distribute feedback form to the program participants to evaluate their experiences while participating in the program.
During the pilot phase, we will use the budget to aid us in establishing partnership and promoting this program. The budget will also be used for renting venues, purchasing refreshment, reimbursing transportation costs of the participant, providing training materials, and remuneration for our trainers. For weekly and monthly FGD programs, the budget will be used to provide reimbursement for peer leaders and trainers for their time, provide refreshment for the training, and rent venues. For the home visit program, we allocate the budget to provide vouchers for the volunteers and procure the materials necessary, such as DH notes.
We expect 15,000 participants, or around 80% of the Kupang elderly population, to be involved in Hakenmes, and we estimated that 60% of them are capable of participating in the regular FGDs, and the rest would require home visits.
A pilot program will involve approximately 10% of the targeted population and cost around $112,000. Meanwhile, the core program is estimated to cost around $1.8 million, bringing the total to $1.94 million.